Hello, my name is Deidre Williamson, and I'm a graduate student nurse at ECPI University. Through casework and studies, master's prepared nurses learn the influence we have on the development and progression of healthcare policy. The realization that nursing's commitment to quality care must extend beyond the bedside was discussed by Sylvia Dingle Stewart and Janice Lacoste in their journal article, Light at the End of the Tunnel, a vision for empowered nursing profession across the continuum of care. Of course, it is not only the desire to make positive changes that will bring a policy into existence. Practical matters of implementation must be considered. One chief factor is the issue of a policy's financial impact. Considerations of cost and benefits must be determined. There are numerous issues in healthcare policy currently, but today I would like to discuss the opioid epidemic and the cost and availability of the medication naloxone or Narcan. I currently live near Baltimore, Maryland. In a February 2017 article in the Baltimore Sun, author Meredith Cohen cited some jarring statistics regarding not only the increase in the cost of naloxone, but the rise in the need for the medication. Cohen reported that a third of the state of Maryland's alcohol and drug-related deaths occurred in Baltimore. With the 2016 data being the most current, there were 481 deaths attributed to overdose, which was an increase from the 393 reported in 2015. While the Maryland legislature has addressed access to naloxone, it has not created a policy to help pay for the medication. Many of the patients who require naloxone administration are Medicaid recipients. Cohen reported that Maryland Medicaid has seen a quarterly increase in naloxone claims consistently over the past 2 years. There were 4,631 claims in 2016 compared to 921 claims in 2015. The Baltimore City Health Department has received grants to help pay the costs not covered by Medicaid. In 2016, the department spent an additional $118,236 for 3,340 doses, which was a 63% increase of spending from fiscal year 2014, when they spent $33,540 on 1,540 doses. When the legislature addressed access to naloxone in Senate Bill 868, the policy focused on giving authority and protection to trained laypersons who administer naloxone under a standing order of a licensed physician or advanced practice nurse. A fiscal and policy note authored by Senator Klausmeier that accompanied the bill noted that the Department of Health and Mental Hygiene had collaborated with its 8 Medicaid managed care organization on policy changes and recommendations to promote changes in prescribing practices based on guidelines from the U.S. Centers for Disease Control and Prevention. In her article for the Baltimore Sun, Cohen reported a New England Journal of Medicine article that stated that the cost of the medication may be limiting and become unsustainable. Realizing that the cost and current policy may put a life-saving medication out of reach for those who need it the most has driven me to advocate for the funding of naloxone distribution. A cost-effectiveness analysis of distribution of naloxone to heroin users for lay overdose reversal was done in 2013 by Drs. Philip Coffin and Sean Sullivan for the Annals of Internal Medicine. Their results showed the cost-effectiveness of lay administration of naloxone, as it often reduces reliance on emergency medical services and reduces emergency department visits. Distribution of naloxone to laypersons was also noted to decrease opioid overdose-related deaths. Encouraging a policy of increased availability of naloxone to trained laypersons requires funding. Many constituents may object to taking funding from other programs to pay for this proposal. While many families are touched by addiction, there remains a stigma attached to drug use, causing some taxpayers to feel this cause is less worthy than others. I would propose that funding to help offset the costs of naloxone distribution could come from a relatively new source of tax income in Maryland, that being from the money of the medical cannabis growers' licenses. Senate Bill 1107's fiscal and policy note, written by Senator Muse, cites that special fund revenues will increase to $1.29 million in fiscal year 2018 from application and licensing fees for growers, processors, and dispensaries. A potential increase in the permitted numbers of growers is scheduled for June of 2018. By sourcing the financial needs of a naloxone availability policy from new revenues, I feel the community and legislative bodies would be more supportive of the idea. Baltimore's Health Commissioner, Dr. Leanna Wen, states in Ms. Cohen's article that naloxone isn't the answer to the opioid addiction epidemic, but it is crucial to keeping people alive long enough to get them into addiction treatment. Thank you for consideration of this policy and its funding mechanism.